So we can't wait anymore to listen to Dr. Taneja about how and when we proceed to a cystoscope alongside, which will be the urological perspective of management of pelvic pain.
So, am I audible?
Yes,
Yes,
sir.
sir.
Okay. So, thank you very much, Dr. Meera, and thank you, Teams Gibbs, for giving me this opportunity. And it is a pleasure to talk to my dear friend, Dr. Durai Rajan, whom we met in Kochi last year, but otherwise it's very difficult to see him. He's as busy a consultant there. So today's topic is pelvic pain, and I believe since I'm amongst the gynecology department, it is a female pelvic pain that we are supposed to talk about. And this slide is very similar to what Dr. Gauri has put. And I have just changed few things differently. So we have arrived at the same concept separately. And if we look at the pelvic pain and we exclude urinary bladder for the time being, the internal genitalia, which you have very well covered, Dr. Gauri, and then talked about pelvic colon. So how do we differentiate? So pelvic colon, if there is somebody who says, I have a lower abdominal pain, which is relieved on passing flatus, I'm perhaps looking at a colonic inflammation. But the things are not as straightforward because there could be crosstalk between the pelvic organs, and one has to be careful in interpreting that. But nonetheless, if that is so, the person certainly requires an expert gastrointestinal opinion. And of course, soft tissue inflammation and infection. I can tell you, there are so many ladies who would come who would have never seen their external genitalia and would not be able to make out because of the chronicity of the disease that they have an inflammatory focus there. Then, of course, the musculoskeletal structures in the form of the muscle spasms and the neuropathic pain that we talked about. So I'm going to restrict my talk to the, and this is how you have discussed chronic pelvic pain without urinary symptoms in a woman. So this you have already discussed, and my job is to talk about the urinary bladder part, because if there is pelvic pain in a woman and everything else is excluded, that is one part theoretically. And here is this lady who's 39 years with episodes of frequency dysuria, pain, lower abdomen, and urethra for 4 years. Now, if you look at the presenting complaint, the presenting complaint is episodes of frequency dysuria. So this is where you differentiate a urological cause of pelvic pain from a non-urological cause of pelvic pain. So if the patient is overwhelmed with a urinary dysfunction or a urinary complaint, along with pain, we must consider it as a urological pelvic pain. And as usual, there are so many people who treat such patients with antibiotics when they sometimes do have a response. We really don't know whether that's a response or a natural flare-up or remission of the symptoms. And of course, the urinary cultures may be positive, but the records reveal in this particular case, I'm getting this case because I'm going to make you visualize a patient sitting in front of you who could have a urological chronic pelvic pain and intermittent periods of complete remission. And she had a pregnancy, and during that period, she was completely symptom-free for 14 months. So obviously, this is how a typical interstitial cystitis or bladder pain syndrome would present to us in the clinic. So when we talk of pain of a urological origin or a bladder origin, we obviously look at the distribution, the exact distribution, whether it's lower abdomen, perineum, vulva, clitoris, inner thighs, lower back, and anus. Now, this pain coming to clitoris is usually neuropathic in nature. There is no other functional organ except sensation. The job of this organ is sensation. So pain in clitoris in all probabilities is a neuropathic pain. And of course, inner thighs, lower back, around the anus is the musculoskeletal pain. So this is how we look at when the patient talks about the distribution of pain. Then we talk of whether there is any aggravating or relieving factors. Now, I will talk of each of them. When was the pain maximum in relation to micturition cycle? So in case there is a relationship of pain with the micturition cycle, then the onus is on the urologist. It's very clear. So somebody who comes with pain and urinary symptoms and pain is related to the micturition cycle, then it is likely that the patient requires a urologist's opinion. Similarly, you very nicely mentioned about relationship between menstrual cycle and pain. So if a deposit on the bladder is there, and it is likely to be endometriosis, so I would certainly involve a gynecological colleague to look at this. Dyspareunia, whether it is superficial or deep. Again, if we are looking at an inflammation of the bladder, it is likely to be a deep dyspareunia. That means there is an inflammatory pathology there. If it is a superficial dyspareunia, it is extremely unlikely that it is coming from the bladder. Of course, it could be because of an overactive pelvic floor, which is also termed as hypertonic pelvic floor or pelvic floor dyssynergia, which can give rise to both superficial dyspareunia and some kind of a voiding dysfunction and voiding frequency, urgency, and a persistent desire to void. So if the pain is related to bladder, it is likely to have a relationship with micturition cycle. So we talk to the patient whether it is, when is it worst? Is it just before passing urine? That means when the bladder is getting filled, the pain is increasing. And once the bladder passes off urine, the pain reduces. So the pain is worst just before passing urine. Or pain starts when the patient starts passing urine. That means pathology is in urethra. And if the pain comes towards the end and persists for some time, then one of the plausible explanations is some erosion in the periurethral and vaginal epithelium, which gets in touch with the acidic pH of the urine, and that initiates burning pain which persists for some time. Another example of a pain towards the end which persists for some time could be a UV junction stone which has been missed, a uretrovesical, what we call the juxtavesical ureteric stone, which can be missed. And that can give rise to a pain like this, or a stone in the intramural part of the bladder, again, can give rise to a pain like this. We've already discussed the dyspareunia part. You've done so well about the examination, Dr. Gauri, that I'm skipping this slide. Only a point that when we talk of pelvic floor spasm, we need to understand whether it is the cause of pain or it is because of pain. So that needs to be clearly assessed. And another thing that you talked of was the psychological factors, the functional factor. Again, we can dismiss that as primary anxiety or a primary hypochondriac kind of a personality, but we should never label it that way unless we are sure that that condition has not been reached because of an organic disease. And that is where many of us will falter and thinking that this is functional overlay because that is how the patient behaves. But why has she been driven to that state needs to be addressed. And of course, lower back pathology. People, especially in India, women who have been sitting on floor and working, mopping, cooking, washing clothes on their knees, their lower back can sometimes be at risk of injury because of poor nutrition, poor vitamin, and of course, lack of hormones in the later age. And there they would have some nerve compression, they would have spasms, and that spasm is continued to the pelvic floor spasm. And that then can present with a lot of things related to the overactive pelvic floor. Of course, we should all look at the history of confusable disorders, and there's a huge list. This is not a theory class, but I brought this slide, and this is what we should remember. Especially in India, we need to look at stone disease and tuberculosis, which are two common things which are not found as commonly in the rest of the world as we have it in our country. And of course, there's a list of associated comorbidities like fibromyalgia, chronic fatigue syndrome. So if a patient has walked into our chamber with one of the diagnoses already made like this, then we must think of something like bladder pain syndrome in addition to whatever the person has, because there is a causal relationship or an association, even if not causal, there's an association between many of these along with the bladder pain syndrome. Why I said not necessarily causal, because it may be, and many times we are still evolving. So many times we really do not know. Maybe 25 years from now, we'll find a common causative agent between any of them and the bladder pain syndrome. Coming to the nomenclature, what do we call a urological pelvic pain? So obviously it started with interstitial cystitis almost more than 200, almost 200 years ago. And then slowly we thought, okay, this is painful bladder syndrome because it is coming from the bladder. And of course, chronic pelvic pain syndrome, where becomes a part of chronic pelvic pain syndrome. And then International Continence Society talked about interstitial cystitis stroke painful bladder syndrome. But then eventually it was decided that since it is not always the bladder which is the origin of the pain, it should be bladder pain syndrome rather than painful bladder syndrome. So BPS is what came out from ISIC. Currently, BPS is a large term, umbrella term, which contains interstitial cystitis as part of it. And when we talk of this in this part of the world, because a lot of doctors, a lot of healthcare workers, a lot of patients would have read interstitial cystitis, so they would get confused if we just write BPS. So I think we should adopt a term of BPS IC. That is how we started with Global Interstitial Cystitis Bladder Pain Society. So we, after having thrashed over and over and over, we came out with the definition, our definition of bladder pain syndrome, which says pain or discomfort in lower abdominal area and or urogenital area, lower abdomen and or urogenital area of more than 3 months duration, which is worst on full bladder, along with one or more of the urinary tract irritative symptoms, with or without standard stigmata of cystoscopy. That is important. We may have absolutely normal bladders, provided another discernible pathology which is likely to cause these symptoms has been reasonably excluded. So this is our definition, and this is a working definition. And I think if we stick on to this, we will do a lot of justice to our patients. So evolution is still continuing, and the latest is that BPS, the bladder pain syndrome, has been split into, we are attempting to split into a bladder pain syndrome, Hunner's disease or Hunner's lesion disease, and a non-Hunner's bladder pain syndrome. There's so many articles in the last couple of years that have emerged, and we will have a standardization of technologies of the nomenclature soon. So if I look at the AUA summary, this is AUA summary 2014, which was published in 2014 guidelines of American Urology Association. They talk of investigations in the form of clinical history examination, urine analysis, and they talk of, in some cases, you should have cystoscopy and hydrodistension. But this is our Gibbs recommendation, which means that we must include frequency volume chart. We must have, obviously, in addition to that, urine analysis. If urine routine shows leukocyte esterase, nitrites, or pus cells, it is certainly infection. So infection is not diagnosed on culture. It is diagnosed on presence of leukocyte esterase, nitrite, and pus cells. Urine culture tells us the pathological organism which is causing these. So many times I find that urine analysis is absolutely normal. Culture has picked up a contaminant and the patient is labeled as UTI. Also, conversely, patients have urine routine full of pus cells, culture is sterile, so they say it is interstitial cystitis because the urine is sterile. So that is not true. So the urine infection is diagnosed by leukocyte esterase, nitrite, or pus cells. The organism is identified with culture. Ultrasonography. We brought in ultrasonography because we have tuberculosis, stone disease, so ultrasonography is important in our kind of setup. Coming to cystoscopy. Now, if you go back, you see cystoscopy is recommended in few in the United States, whereas cystoscopy becomes important because one, of course, in today's time, we have to be careful about litigation. Now, in the last few years, I have seen so many patients treated as bladder pain syndrome or interstitial cystitis. And when they reach me and I do a cystoscopy, I find a tumor or tuberculosis. And I'm not the only one who has found these. So many other of my colleagues have done that. And then it becomes very bad because it is ugly if somebody decides to sue the doctor. So I think we should encourage cystoscopy as mandatory when we make a diagnosis. And of course, if you do a cystoscopy and you find something, you should not leave it. If you find a Hunner's lesion, you should ablate it. If there is a small capacity, you try to distend it. Or it should be done under general anesthesia. And of course, if you see a lesion, it must be biopsied. That there is no doubt. As I said, urine culture recommended only when there's urine analysis indicating infection, urine cytology if there is microscopic hematuria. Of course, symptom scores, quality of life scores, and urodynamics have their indications which are not universal for all patients suspected to be BPS. Cystoscopy is not essential for diagnosis of IC-BPS, but it is important to exclude the other pathologies. It should never be done under local anesthesia. And initial look should be maybe absolutely normal unless you distend and you find maybe a lot of things. It gives you opportunity once you're doing it under general anesthesia to do a hydrodistension or ablation of Hunner's lesion. And I said, your eyes will see what your mind knows. This is a typical Hunner's lesion. There's a whitish, beige white center of a pale center with parallel radiating capillaries like a star, and rest of the bladder is normal, which is important. So if you have an infection, tuberculosis or radiation cystitis, the whole bladder is involved. But here there is a patch which is involved and rest of the bladder is normal. Pathology to exclude other pathologies like carcinoma in situ, eosinophilic cystitis. We've seen all of them and that's why a biopsy must be done. Thank you very much. I finished my talk here.